Hydrocephalus is a severe condition affecting all ages, with various causes. Common symptoms include disorientation, headaches, cognitive and developmental changes, vision and sleep disturbances, and gait abnormalities. The effectiveness of CSF diversion as a surgical intervention suggests a common cellular and molecular dysfunction with various etiologies.
The term hydrocephalus was first reported by Hippocrates. Still, the term was not coined until Celsus's writings, sometime between 25 BC and 50 AD. Anatomists like Galen and Antyllus attempted the first surgery but were unsuccessful. Later, 17th century anatomists like Willis, Monro, Magendie, and Luschka began unraveling the brain's architecture. The 1800s and early 1900s experimentation with material science and the Walter Dandy phenylsulfonphthalein dog model injection led to our modern understanding of communicating and non-communicating hydrocephalus.
Hydrocephalus is characterized by abnormal cerebrospinal fluid accumulation, either with or without changes in intracranial pressure. It can occur due to compensatory mechanisms such as cortical tissue or skull expansion. The normal flow of cerebrospinal fluid is from the lateral ventricles all the way to the subarachnoid space. Communicating hydrocephalus occurs when the bulk of flow is unobstructed, resulting from a failure to absorb CSF or via overproduction. Non-communicating hydrocephalus occurs when there is an obstruction to normal CSF flow throughout the central nervous system. Despite this simple diagnostic criteria, there is a significant clinical heterogeneity among patients with hydrocephalus. Classifications of hydrocephalus are either primary, which can be syndromic or idiopathic, or secondary to another condition.
Various factors including infection, hemorrhage, and traumatic insult can cause secondary hydrocephalus. In developed countries, post-hemorrhagic hydrocephalus is the most common cause in pediatric patients, affecting 40% of premature newborns. In developing countries, infections of the central nervous system, such as meningitis, are more common, leading to post-infectious hydrocephalus. Adults are also at high risk for developing new injury-induced post-traumatic hydrocephalus, as head injury can damage neurons, glial cells, and blood vessels, affecting CSF production, flow, and drainage. Traumatic brain injury, TBI, has increased the number of adults living with post-traumatic hydrocephalus, potentially reaching 2/3 of current and former military service members who suffered moderate to severe traumatic brain injury.
Hydrocephalus patients can be treated with transient non-surgical interventions, transient surgical intervention, and permanent surgical treatments. Non-surgical interventions include acetazolamide, hyperosmolar therapy, and hyperventilation. Transient surgical interventions involve intermittent and continuous cerebrospinal fluid drainage techniques. Neuroendoscopic lavage, or NEL, is currently being studied for the removal of intraventricular debris from infection and hemorrhage. Permanent surgical interventions involve overcoming obstructions using neuroendoscopy or via placing a shunt to effect CSF diversion from production within the ventricle to absorption within a body cavity, like the peritoneum, which is in the abdomen. Permanent CSF diversion is associated with high risk of failure and often requires re-intervention. However, it still remains the gold standard of treatment, which is permanent treatment via CSF diversion and shunt placement.